could you please plug my headlight in, please?
We'll have to re-advance in a minute. Okay, let's go ahead and finish
So her pressure's been in the 160 range the whole time, but she's normally in the 140.
We have section on, please.
Hemostat, please. I'm just going to try to be very fastidious here. Hemostat, please. The bigger the problem, sometimes, the greater the opportunity to impact and improve things. That's a blessing and a curse. You know, we take care of very sick patients, but there is an opportunity in those situations to do a great deal of good, not just technically, but also with interacting with families. They're very concerned. They come in with a situation that they know would get the better of them if it's not intervened on. And in those circumstances, it's a privilege to be in a position to impact on those patients. And also, because this profession requires such a level of focus and expertise, there's no question that you need to be focused, to work with a team, and to give it your very, very best and your all. So there are very few, I think, professions where one is asked to give their all on a regular basis, and that really is wonderful.
I have to admit that when I first came out of training, it was a little bit of an anxious time for me, especially in the more sick individuals. But I always felt, I mean, the staff here is phenomenal. All of our nurses have decades of ICU experience, and we are fully equipped to deal with pretty much anything that can happen in the lab.
It gets hardest when you're trying to make really hard decisions. It ends up being a group decision of, you know, well, we haven't run into this before, and we've asked around the country, and nobody else really has either, so what do we think the best thing is? It's a lot easier when you know predictably what to tell patients. Okay, if we do this, this will be the outcome most likely, and if we do this, this will most likely be the outcome.
Okay, where do you want to start? Your side? The difficulty is not just in the how big the issue is and how, you know, this is life and death, and a small variation can affect the life of a 29-year-old. To be an 80-year-old for that matter of fact, but it's the how are you present enough to give your all. So it's just learning when to relax and when to focus and how to deal with pressures, and that just takes time. Kimberly, how much since the last? Okay, so once we get this graph down, it's going to be a good time, which is probably going to be about 20.
I finished a triathlon, crossed the finish line, and instead of my heart rate going down, of wearing a heart rate monitor, and I just watched it. I'm going, gosh, this is kind of weird, and I watch it, and it's going up and ramping up and up and up, and it gets to, you know, I raced at about 150, and then I'm looking at it, it gets to 170, and then 190, and then 220, 230, and then the next thing I know,
but he went down.
the next thing I know, I just kind of grabbed Carrie's shoulder. My dad was there as well, and just grabbed her shoulder, and enough for them to look around, and I was down for the count. So it was enough for Carrie to, you know, basically force me in to see the doctor. I'm this 30-something-year-old guy who's running triathlons, thinking there's nothing wrong with me. Over the time, I went through a couple of different cardiologists. They were trying to figure me out. I kept being told I'm kind of this anomaly. You know, here I am wanting to train for an Ironman, and they can't get their patients to walk to the mailbox and back. And nobody really knew what to do with me except every 6 months get an echo. So I did that, and I kept getting these atrial fibrillations, and nobody was able to identify it, so we didn't really know what it was. And I went out of frustration and saw my primary care doc, and he said, you've got to get to the U. You know, you've got to get to the U, and they'll be the ones where you won't be an anomaly there. They'll be able to figure it out.
And we just review what we're going to do in a second. Okay, so we're going to go on bypass. I'm going to put my lower cable tape in the antegrade quadriplegia. I'm going to try to isolate beating heart, the right pulmonary veins, and do the right side of the maze. Then we'll arrest, okay? I'll take a knife and a tonsil and a CO2 line.
I'm not doing anything now. I mean, this is why I'm so ready and eager to get in and get this done, because I'm walking on eggshells. I mean, I'm afraid that if I go out and train and run, and I know that I've been told that I can do things in moderation, I'm not a guy who really does things well in moderation. And so I'm afraid if I get out there and start doing these things that I'm putting myself at risk. So I've become a little more sedentary now, and it's driving me nuts. It's why I'm just ready to get this done. So 3 things. get the aortic root fixed to hopefully spare the bicuspid valve, and also go in there and do an ablation on wherever these atrial fibrillations are going, get it all fixed. When I'm done with this, I'm doing an Ironman. I mean, that's the goal.
You're at 1100. Okay, turn it off for a moment. Vent on.
Patients have a lot of anxiety around surgery. And to have a surgeon who can go in and talk to a patient and address those fears and make the patient at ease, I think is very, very important. The bond between a physician and a patient is a unique one. And when that bond is strong, it clearly has an impact on how patients do.
One of the most important things for me to get me motivated to do these things is to get to know the patient and the family and to create that bond. It's not just, well, there's a disease X that I'm dealing with, but there's an individual that happened to have disease X who has a major impact. They have family, they have responsibility, children, relatives that are very, very close to them. And when you make that bond, it's an incredible experience. My problem with it, David, is if it doesn't work, you need to take the entire bottom out because you put a mechanical valve, it's going to be tiny now. We frequently see patients with multi-dimensional problems, all of which need to be addressed. So in this person, we need to replace the aorta, reshape the valve itself and try to repair it, address irregular heart rhythms. And this sort of level of care requires multiple specialties. Okay, stop the cardio.
All right, it's a total of 600 now.
Okay,
Please
off. Is it off?
We're off.
Okay, there's only one way to make it fast, is not making mistakes and doing it only once.
People that are born with childhood defects are living longer and longer, and they said that like people my age are sort of the first on the crest of the wave, and we're living longer and they're kind of still learning with us, and they need doctors that can help people make that transition from from childhood to adulthood. And now they actually have, I mean, that's what they're working with Dr. Stout, is to get people that can, if medicine's allowing you to live longer, you need somebody that can help you get there.
Patrick, do we have a room? Perfect. Okay, the scenic tour, as always,
Okay.
of our various rooms. Carol's going to
I was born in Seattle and I started at Children's and had my first two surgeries there. My first one when I was a baby, and the second one when I was 23.
Morgan's awesome. She's got I think, a spectacular attitude for handling a difficult chronic disease. I like working with the age range of patients that we get, because we do get some definitely older patients that are more typical of an internal medicine or cardiology practice, but most of my patients are in their 20s and 30s. They're in their 20s and 30s because that's who has adult congenital heart disease for the most part. I think the thing that gets to some of these guys to a certain degree is that there's a lot of uncertainty, because the surgical treatments that kept them alive or made it even possible for them to survive weren't available usually until the late 1960s, early 1970s. So a lot of these guys, this person with this anatomy, there isn't anybody over the age of 35. So they're kind of looking around them. First of all, they're the only person cruising around within their peer group usually who's got any heart anything. And on top of it, they kind of just don't know what the future holds for them. Morgan may be on kind of the farther end of her type of disease, because there's not a whole lot of folks older than her, largely because the folks older than her died before they had a chance to even get out of childhood, because none of the surgical approaches were available. As her mom said, everybody else just told her, she's going to die in a couple of months, you don't need to do anything. And Dr. Stam said, why not? What do you have to lose? And lo and behold, here she is 40 years later, and she's doing great. Relatively speaking, she definitely has bumps in the road, obviously. Dr. Rowe got to spend a good 12 hours with her trying to get rid of some fairly annoying heart rhythms. She does a good job of taking care of herself, pays attention to her own symptoms. But she's an awesome patient to take care of, because it's a really good working relationship.
I think they appreciate that I'm paying attention and don't expect them to be responsible for everything. It's like, I as the patient am responsible for my caring about my health as well. I don't, can't expect a doctor to just give you a pill and make it all feel better, because that's not the way it works. It gets, when you have those arrhythmias, it goes on and off like a light switch, and you never know when it's going to hit. And it can just, just, you can be, just having a conversation with somebody and all of a sudden, boom, it pops. And you can't, I have trouble breathing. It's not painful, but it's really discomfort. It's a lot of very uncomfortable. And it's like, I feel like my heart's going to pound right out of my chest. But then when they get me out of it, either with a drug or sometimes they zap me, and it's just like turning a light switch again, and it's like everything's cool. So, and I'd rather not go into them if I don't have to. And that's why I agreed to do this.
Hi, Morgan.
Hi.
How are you?
I'm fine. How are you?
Nice to see you. How you been feeling?
Pretty good.
Yeah?
Very good, yeah. A little slow, but good.
Now, tell me a little bit. Terry told me that you had a little bit of palpitations one night before going to sleep.
Yeah, I woke up in the middle of the night with them, and it wasn't racing, and it wasn't really pounding, but it was out of sync.
Okay.
And so something was going on, but I was so tired, I just fell back asleep, and it was gone when I woke up.
Okay.
So I figured that's good enough.
When you look at the trend of what your arrhythmias have been doing, and you look at the time since your ablation, do you think there's been a significant decrease in the amount of arrhythmias you've been having?
Yeah,
Yeah.
I think that I haven't had, and even though, like the last time, I was still getting them, but even though I was converting myself, I was still getting them, and now I haven't had anything like I used to get.
It sounds to me, though, that it's pretty minor in comparison to the more sustained bouts that you were having before that were bringing you into the hospital.
Yeah, no, it's definitely much better than it was.
Good. So we're slowly making progress.
Yeah.
As you know, we're working very closely with Dr. Stout in the congenital clinic, and between our focus on the arrhythmias and her focus on your overall hemodynamics, we're hoping to, keep you healthy and keep you out there living your life the way you want to.
Okay, so I can be skydiving by now. No, I'm kidding. Sometimes I want to move to the ocean or something, and I'm afraid to be out of reach of the UW because it gets scary. Scary to go to other places where they don't know you.
I'm very optimistic about the way you're progressing. I mean, the idea is if you draw a line and see the way you're going, you're definitely heading in the right direction.
Yeah.
I think your next stop is with Dr. Stout, right?
Yeah.
And we'll have her look you over from the standpoint of your heart as a pump, and the three of us will get you, back to 100%. Okay.
Okay.
She definitely progressively has been feeling better.
Okay. Has she had a CBC check yet?
It's been a little while. So
Okay. We can
I'll
get one today.
leave all that up to you.
Thanks, dude. So, rumor has it, you're doing all right. Okay.
Yep.
Slowly perking back up again.
Yep.
You'll look good. As you frequently do. Let me just take a quick listen here.
I haven't been here since I left.
That's a good thing.
That's the way it should be.
Exactly. Social visits only every 6 months to a year.
Yeah.
Thanks for agreeing to come to the support group.
Yeah.
There's other people out there
Yeah.
who have at least congenital heart disease, even if it's not exactly the same flavor.
Right.
And especially for people who are younger, to realize,
Yeah.
hey, look, there's people much older than me who are actually
You can be
doing
as old as me.
exactly, exactly. Old and decrepit, it'll be fabulous.
Yes.
All right, we'll spring you.
Okay. Thanks.
So, labs, we'll give you a call if there's anything squirrely or want to change anything.
Thank you. Okay.
See you next time.
Take care.
You look great.
Thank you.
Holler if anything gets
Okay.
off.
My heart and everything is doing a lot better. I don't have to come back for 6 months. That's good.
We're gonna hang up the third pseudocomisture, that's why.
Okay. Okay, take out the red rubber. When you think you're in the middle of the leaflet, I'm just gonna take a tonsil. This is the strongest part
Right here, yeah.
because it's more fibrotic.
This is also the
It's on
part
a
that-
membrane. The most amazing thing is it's not just the science itself, but how you apply it. And there's so much variability in how you apply it. That's where the art comes in. Part of it is experience, and part of it is fitting not just facts, but gut feelings and experience into the situation and continuously innovating.
It's fine.
Let go of the
Yep,
pickups for a
that's
second.
it. Go ahead.
The aortic 27.
Yep.
Yeah.
I saw it. I saw it.
I've been doing heart surgery since 1986. The university gets referrals of patients that cannot have surgery in the outlying areas in the Pacific Northwest. And so the quality of the surgeons here are the best in the world, and also the nurses. We work on patients that cannot be worked on by other surgeons in surrounding areas, and these are usually the high-risk patients.
Do you know how lucky we are? We have both Sonia and Sarah in the same room.
When I first started working here, they would wheel a patient into the door, and I'd think, oh no. And then the patients would survive because the surgeons that we have a lot more experience with those difficult patients than other surgeons, and so this is the best place to come if you need surgery for cardiac. I really believe that. So we'll make an incision. There'll be a bovie. There'll be lots of cauterization because we have to cauterize all the bleeders. And then they take a saw and they'll saw open the chest. As one of the surgeons has said to me, it kind of gets in your blood, and I've been working in heart surgery ever since.
If you're having surgery, that's one thing, but when they're working with your heart, you know, you really want the best. And I feel that that's what I've got.
Hello, Mrs. Oasis. How are you?
I'm fine.
It's nice to see you.
Again.
Again. How do you
Yeah.
feel since I last saw you?
Okay.
You feel okay?
About the same.
You've still been having the palpitations?
Oh, yeah.
Really?
Yeah, last
Okay.
couple of days have been more severe than before.
Okay.
Probably anxiety.
Right. Well, I want to make sure that you don't have any other questions with regards to the procedure we're doing today. Some of the team earlier came by and told you what we're going to be implanting is a permanent pacemaker first.
Right.
And the procedure is going to be performed here in your left shoulder.
Right.
The access is going to be through a vein that runs right underneath your collarbone. We'll place a special lead through that vein into the right ventricle. The lead has a tiny little screw that screws out, which holds it into place.
I'm just so glad that I'm
then
living in a
we'll-
time when they can do something. I'm a very active person, and I cannot be as active as I would like to be, and that's difficult for me. So I'm just glad that something can be done.
Okay.
Yes.
So how do you feel? Are you reasonably comfortable right now?
Oh, yeah.
Yeah?
Yeah.
Okay, good.
Okay.
Okay. The team will be coming up to pick you up very shortly.
Okay.
And we'll make sure that we talk you through the whole thing. Okay, so you just need to communicate with us how you feel through the whole thing, and just help us keep you as comfortable as possible through the whole procedure.
Alrighty.
Okay.
Sounds good.
Okay, it's good to see you
Again, right.
again. I'll see you soon.
Right.
Okay? The particular device we're using has an algorithm in it that will try to minimize the amount of arrhythmia she has. So it'll be very helpful not only in supporting a very regular heart rate, but also in the follow-up as well. Okay?
All right.
All right.
Thank you.
Very much my pleasure. It's an area where we can impact a lot of people's lives, and whenever you're doing something where you wake up in the morning and you know that you can positively impact somebody's life, it's a good day. And most of our days are like that. Each case is very unique, and we try very hard to make sure that we, treat the individual. And you have to take all of their other coexisting medical problems, their life circumstances, their psychological profile, their own personal philosophy about what they want with their lives under consideration before deciding to put these in. Okay, I'll see you in a little bit. Okay, Patricia, we're going to go ahead and get started, okay?
Okay.
And do you feel this at all?
No.
No? Okay, we're going to go ahead and start. If you feel anything, please let me know, okay? Just following me down here. I'm already coming down. Can you give me a little wet gauze? When we first saw her, she was having a lot of different arrhythmias that really impacted the quality of her life. She felt a lot of palpitations and was short of breath at times. Elizabeth? Yeah? I'm going to need you to drive slow, please. Elizabeth, I really need you over here. How are you doing, Patricia? You doing okay?
I'm fine.
Good. Everything's going very smoothly. Okay, let's go back to the center of the chest and let's look at the lead lengths. we have suction on, please? We're just closing the pocket now. Everything is in place, and we should be finishing up here in the next 5 to 10 minutes, okay? But looks pretty good, so you'll be able to wear a bathing suit and be able to wear it pretty proud, okay? I thought it went pretty well, and I thought she was pretty comfortable through the whole procedure. And she'll have a very short convalescence, but people typically tolerate the post-procedure period pretty easily. Okay, it looks great. We're going to get you uncovered now, okay? I'm always anxious about everybody that I take care of. I want to make sure that they do well. And I think a certain amount of anxiety during a case is healthy for those of us who are doing this. Hello, Mr. Weeses. How are you?
Hi. Okay.
It's like a pretty... I guess you were expecting to wait quite a long time.
I was.
Well, everything went very well. We implanted 2 leads. It's a nice device, and I think it's perfect for her. Okay. The procedure itself went completely smoothly, and all the lead parameters look great. And if everything goes well, we'll let her go home tomorrow. Okay.
Well, thank you.
Sure. Do you have any questions at all?
No, I don't think so. I think you explained it all pretty well.
Okay.
Yeah.
Very good. I'll see you upstairs then.
Okay. Well, thank you.
You're very welcome. Bye-bye. I've always been attracted to heart arrhythmias. I've always been intrigued by them. I always thought they were interesting. And so it was just a natural for me to head into cardiology and then cardiac electrophysiology. It's quite a field. It's a field that is advancing so fast. And it's one of the few fields in medicine where you can actually affect a cure on individuals. There are many strategies that we have, or many techniques that we have, that can effectively cure over 95% of these individuals with recurrence rates of these arrhythmias in the 5% range. Mrs. Cole is here in follow-up status post her
I think that attracts the Dr. Rose, the Karen Stouts to an institution like this is the fact that we do not only offer a diagnostic piece of this, but we can do something about a lot of these diseases. There's some we can't, but many we can actually intervene on and change the quality of life and the longevity of individual patients. What we do for acute myocardial infarction or heart attack now versus what we did 25 years ago is like modern technology versus the Stone Age, and it's only a quarter of a century ago.
Can we have an aortic retractor,
Can you guys
please?
get a message to the wife that we're trying to save the valve and things are okay? She was really nervous this morning.
Well, you can only be in one place at a time. And the hardest thing I think for all of us is as soon as you have an incredibly difficult situation sorted out, there's somebody else who's sick. Or, in fact, while you're working on somebody and you're giving a situation your full attention, you get interrupted by the next emergency. And so the abilities to triage and give everybody their full attention regardless of what the circumstances are is very challenging. I think that for me is the most difficult issue.
Big 3, man, you gotta be thinking. Your job is to make our job easier. Anticipate, don't act like a medical student. See that?
Yeah. How does it look? Look and see how it's lined up, Chris. Well, you know what? Let's wait until she's done with the cardio. There's too much. This is very critical.
You make a beautiful schedule and 30 minutes later you're redoing the entire thing, or it changes on a really patient to patient and moment to moment basis.
The only way to make that not prolapse is to massively foreshorten about half.
No, I wouldn't do that. If we get to that, I would put a stentless route.
I think that's where we are now. Look at this. Because that's what I just noticed is it's perfectly lined up.
Yeah.
And this leaf foot here.
Yeah. No, I agree with you.
Give me another pair of pickups.
Yes, please. And then we'll take budgeted stitches.
No, it's just too big. What happened is the annulus got a little bit smaller, and now this is prolapsing in. He's going to have massive AI.
Okay, let's take it down. Okay. Chris, I believe it's the right decision.
Yeah.
We tried to preserve the aortic valve, and it looked like as we were doing it that there might be a chance that the repair would not be very durable. And so at a time of surgery, we had to change the plan to replace it with a different kind of prosthesis and a slightly different operation. We essentially completed most of the first operation, looked at it, it looked like it would not work long term, and so therefore we went to a different plan, which we sort of had ahead of time of what we would do if that was the situation.
Now you're seeing another operation.
Yeah, while you're here. No, this is disappointing. But I don't really know how we could have done this differently.
The pledget is on the outside, so.
No, what's it?
11 blade.
So you still have some more graft to attach to what you've got there? I just want to know that we've all hashed through exactly what we want to do and what we think needs to be done, and everybody's on that same page. And I would far prefer, everybody would, to have them recognize it now and replace the valve rather than recognize it in 3 weeks, 6 months, a year, and have somebody having to come back to the operating room.
Okay, look at this. This is just jumping over here. Look at it. It just loves it. Look. Oh, man. I think it looks beautiful, Chris. if you ask me.
No, I like this operation. And in fact, if it was me, this is probably the operation I would have.
That's what I would have too with a bicuspid.
But,
And then hope that somebody can just cut out the valve and put a St. Jude
right,
in
well, that's
the
why I
middle.
want to put 27 and he'll be able to put a 25
25.
St. Jude in here.
I don't think that people understand the responsibility that people carry. We operate on very, very sick patients, and sometimes we are going into a situation where the risk of this particular individual not surviving is 50 or 80%. And even though our outcomes are 3 times better than the national average, regardless of that, to be in this profession, you live with it and you take a personal responsibility that maybe, had you thought this out a little bit differently, maybe you could impact on the outcome. And we live with it.
It's really been incredibly advantageous. The learning curve has been really steep over here, and I really feel like we're able to provide the care we'd like to be able to do, and we can continue to expand that. I love this job. It's very cool.
I think what makes me enthusiastic about what I do is really the interaction with the people in this institution. I think it's a very dynamic and vibrant place to work, constantly changing. The thing that makes you want to get up every day is the fact that you're working with outstanding people and you can really make a difference.
It's different all the time. You have to be very chameleon-like and like change, because here it changes all the time.
It's a very attractive field in that you get a tremendous amount of gratification in taking a patient and then being able to provide a number of different therapies for them. It's a very rewarding area to be in.
We absolutely live with both the blessings and the scars of our experience. It is an opportunity to really open yourself up and experience your own life and those around you even more than before. So it depends on how you take it. It's an incredible opportunity.
Beautiful.
Now it's 25 instead of 27.
So if there's any better than that, I'd have to light up in the operating room.
We're going to let you go back to your room soon. We'll give you a little something for the discomfort you'll be feeling over the next day or two.